Hello, everyone. Welcome to our presentation today from Brain Trust, Conversations in Psychopharmacology. I'm Dr. Joe Goldberg, Clinical Professor of Psychiatry at the Icahn School of Medicine in Mount Sinai in New York, welcoming you today to our ongoing series and conversations with experts in psychopharmacology on topics of, well, topical interest and controversy in psychopharmacology. I'm really thrilled that today our guest on the program is my longtime friend and colleague, Dr. Holly Swartz. Holly is professor of psychiatry at the University of Pittsburgh School of Medicine. She's also the president of the International Society of Bipolar Disorders. She's also the editor-in-chief of the American Journal of Psychotherapy. Holly, welcome.
Thanks for having me. It's a pleasure.
So good to see you. So I'm going to just get started right away. Our topic for today is really around your area of expertise, which is evidence-based psychotherapies and mood disorders and their interface with issues psychopharmacologic. Oh, I forgot to mention Holly is also an officer for the American Society of Clinical Psychopharmacology. So she speaks both the languages of psychotherapy and psychopharmacology. So if I may, Holly, let me start by asking you this question. Put on your clinician cap. A patient comes to you for an evaluation. You do your formal assessment. You make the determination that they have a major depression. And then the question is the best treatment for their depression pharmacology, psychotherapy, or both?
Yeah, it's a great question. And I think the answer is rather nuanced. The short version is either one or the combination is fine, especially for less severe depression. So evidence-based psychotherapies for depression, and among these, I think about cognitive behavioral therapy or CBT, or interpersonal psychotherapy or IPT. So psychotherapies that are specifically developed and tested for depression. So evidence-based psychotherapies have comparable effects to pharmacotherapy in patients who have a more moderate or less severe form of depression. If somebody's more severely depressed, they're perhaps having active suicidal ideation, they're really, really struggling, antidepressant may yield just maybe a modestly greater effect than psychotherapy, and perhaps even more importantly to this conversation, the combination of psychotherapy plus antidepressant medication is probably more effective than either intervention alone, especially in these more severely depressed individuals. So I think we want to personalize that recommendation based on at least one of the parameters we're going to base it on is the severity of the current depressive episode.
When do you start out with as you just described, there's value and evidence based to support either psychotherapy or pharmacology or both? Should we start with one and then contemplate an augmentation of the other? And if so, which should come first? How does the chronology work that way?
So a lot of it's going to be patient preference, right? So because both psychotherapy and medication work, pretty comparably well, again, in our less severely depressed patients, the issue of patient preference matters a lot, as does issues around access. If a patient would prefer to start with an evidence-based psychotherapy and they can get access to either a therapist in person or virtually, then it's entirely reasonable to start with an antidepressant psychotherapy, see how the patient does. And, like medication, effects are not immediate. We want to give somewhere on the order of, for psychotherapy, 6 to 12 weeks to know whether the psychotherapy is having an effect, at which point it makes sense to either augment with an antidepressant, perhaps in this case, or switch to another psychotherapy modality if that is preferred. So I think kind of the roadmap is really similar to what we're going to be doing in pharmacotherapy, which is we start with monotherapy. And then if we don't see a response in a reasonable period of time, it might take a little bit longer for psychotherapy to take an effect than antidepressant medications, but we're going to give it, a bunch of weeks, unless something arises where we need to intervene more rapidly, and then we can consider augmentation or switching.
So, Holly, when you're talking about patient preference between psychotherapy or pharmacology or the combination, How important is that as a moderator of outcome? Does that influence the likelihood of success or more just patient engagement, staying with it, not dropping out? How exactly does preference impact outcome?
Uh, yeah, patient preference is a really important moderator of treatment response. In our study, actually, so that now we're talking about this was in a group of individuals with bipolar 2 disorder. People, and we were comparing psychotherapy alone to psychotherapy plus medication, and people who got their preferred treatment actually had a 4 times greater likelihood of responding to treatment. So getting what you think is going to help you feel better, get better, actually matters a lot.
Now, let me ask you this. Is there any potential for, let's call it confounding by indication on that one? In other words, let's suppose that um, I am very aware that I've got elements that lend themselves to psychotherapy. I've got interpersonal issues going on. I've got some biases in my thinking. And so my preference is based on, I know the mechanism of action of the treatment, as opposed to, I know that I'm melancholic. I wake up at 3 o'clock in the morning. I'm anhedonic. And so I am privy to the knowledge that psychopharmacology may target some of those kinds of vegetative features. What I'm sort of asking, is it just sort of preference in a kind of a willy-nilly way, or is it more to do with, you know what you need because of the nature of the symptoms that you're experiencing, if you get my
Uh,
meaning?
I mean,
Best guess.
that's a pretty nuanced analysis of one's presenting problems. I will say that people who are depressed often have some cognitive degree of cognitive impairment. They're having trouble making decisions. And so, the capacity to engage in deep reasoned thinking around these kinds of predictors of response probably are less robust than when somebody is not depressed. And so, again, from an empirical standpoint, I don't think we know the answer to that question. From like kind of a gut response, I feel like people have kind of a feeling about what they prefer and what they, more importantly, perhaps what they don't want. Like some people really are skeptical about medication or concerned about side effects. These may be women in childbearing years, and even though we know that most antidepressants are very safe during pregnancy, a lot of people have sort of a mythology about not taking. Well, they want to minimize risk during pregnancy. Totally understandable. I mean, so there are lots of reasons why people may want or not want one modality or the other. I'm not sure that there's data to parse out exactly what predicts,
Right.
preferential response in that domain.
Let me try to do some damage control on what I was asking about. It may not be the patient's self-awareness of those ingredients, but your assessment. Let's suppose, for instance, I come to you and I'm interested in psychotherapy. For whatever reason, I don't like medicine and side effects. And in the course of working with you, start to notice that I'm very psychomotorically retarded. It's kind of hard to shift sets or look at things from alternative perspectives. And you're beginning to wonder about things like cognitive rigidity and my ability to sort of think about things from alternative points of view. And it might start to cross your mind, Joe might not be able to engage in the work of the kind of psychotherapy that, say, a CBT or even an IPT requires without the lubricant of the pharmacology. And in that instance, how would that assessment on your part juxtapose with patient preference?
Again, those things are pretty subjective. I think rather than an answer that I could give you based on the evidence, at least as far as I'm aware. But I would say, so if somebody has, sort of rigidity, a lot of melancholia, they're really slowed down, they're probably going to be in general more severely depressed. And so, again, just based on depression severity, there's reason to think about using medication either alone or in combination with psychotherapy. So I think, from those kinds of dimensions, it would definitely point you in the direction of pharmacotherapy. Whereas if somebody is pretty reactive, conversant, that, they definitely meet criteria for a major depressive episode, but have, sort of maybe are, if we do a standardized assessment, there may be in the more moderate range or the less severe range. And they're interested in either their cognitions or their interpersonal experiences that might, point me towards saying, yeah, well, why don't we give CBT a try, or why don't we give IPT a try and see how you do? And if that is not sufficient, if that doesn't really get the depression symptoms under adequate control, we can always add medication.
Now, very helpful, clarifying. Thanks. Among the evidence-based psychotherapies for depression, I would think that there are different mechanisms of action. And in my head, I would imagine CBT would lend itself to someone where there are some very obvious cognitive distortions and patterns of thinking that are worth holding up to the light of day and challenging those distorted thoughts. Whereas things like IPT or IPSRT, one would think about, well, the things that you and others have written about, role transitions, the interpersonal impact on mood. How much do the active ingredients in your mind of the differential psychotherapies for depression come into your play?
I mean, so again, this is kind of a holy grail, what works for whom. So
Yes.
you're asking the hard questions, Dr. Goldberg.
I know.
It's been hard to reproducibly identify a priori predictors or really, yeah, moderators of response to one treatment versus another. I think one that we kind of consistently see is you have to have the stuff to work with in order for the therapy to work. So if somebody has significant cognitive impairment, CBT actually doesn't work as well as IPT. In IPT, we can work with somebody who has some degree of cognitive impairment, focusing more on their interpersonal experiences. And the converse is also true. If there isn't much happening in the person's interpersonal life acutely, it's a little bit hard to get traction with IPT, whereas CBT doesn't really care. And they might, and CBT can be used to really then focus in on cognitions independent of what's happening interpersonally for the patient. So the way that I think about it is you've got to have stuff to work with in order for the treatments to be effective. And we have seen that differential response to IPT and CBT.
So, Holly, what is this concept known as psychodynamic pharmacotherapy? This concept of something integrative about the way you think about medicines and their meanings to the patient, and a good pharmacologist has some sort of meta-awareness of, well, some of the psychological attachments and expectancies that patients bring to bear about their medicines. Can you speak to that?
I know that is a great question. David Mintz has written extensively on this topic and has published a book on psychodynamic prescribing. And so it's really an interesting area at the intersection of psychological processes and pharmacotherapy. And I think some of the take-home messages of this line of inquiry include the idea that medicines have psychological meaning, that when we prescribe, we are giving the patient a concrete representation of caring. It's an intervention that means something to the patient, and based on the patient's psychological makeup, they may have a response to the act of prescribing that may contribute to, say, non-adherence to medication if they're have issues with insecure attachment, let's say, and they're skeptical of the prescriber, feeling like there may be trust issues because of historic experiences with attachment figures. They may be less likely to follow the prescriber's recommendations, or they may feel that the literal object of the pill that is being given to them is something that may be harming them, even though it's being done in an informed way. Conversely, if somebody has secure attachments and they maybe even to some degree idealize the prescriber as the source of goodness, of a kind of connection and attachment that they typically in their past have found to be positive, they may be more likely to follow the recommendations of the prescriber and indeed feel that the concrete object of the pill is a path towards maintaining a connection with their prescriber, even when they're not in the office, that it's a reminder that somebody cares for them, is looking out for them, and it can be something that enhances the pharmacotherapeutic experience.
So even if you're not psychodynamically minded, there is something to be said for the idea of medicines as transitional objects. That is a little piece of you as now a representation in the form of this pill that you will take and put within yourself 24/7, sort of always carrying around a little bit of this uh, meaningful expectancy of health. Is that fair to
Right. So
say?
transition objects, right? So that comes from the psychoanalytic, psychodynamic literature. This is a concrete representation of your attachment to an important caregiver figure. Kind of the classic transition object is the blankie that a small child kind of keeps at hand to keep their mother close. And so this is, indeed to some extent what's happening even in adults, where objects that are given to us by either valued caregivers or possibly the opposite could be true if things aren't going well. But in the case of a valued caregiver, this could be something that allows the person to feel that connection to their prescriber, even in the absence of their actual physical presence.
And given that 30 to 40% of drug response is thought to be placebo specific, do you think this could be accounting for some of the active ingredients of the placebo response of medications?
Oh, I love that.
I'm giving you the good questions today,
You're
Holly.
giving me the good questions, right? I love that. Look, I mean, it's really interesting because psychotherapy and psychological treatments have been siloed off from pharmacotherapy, and really, this is to the detriment of our field because it's impossible to isolate the effects, the biologic effects of these interventions without considering what's happening in people's minds, because we're complex organisms and the psychological processes continue to have an impact even when we're engaging with a biologic substance. And so both are true. And so being able to combine these ways of thinking about healing processes and pathology are important because it allows us to think more holistically about the person in front of us, because they're not, just a series of neurotransmitters, although the person has neurotransmitters that can be modified by medication, nor are they just a person with psychological representations deriving from early childhood experiences. It's really a complex constellation of contributors to who the person is and how they respond to help seeking behaviors or help accessing helping behaviors.
Good psychotherapy, however that gets defined, that just changed the brain, right? I mean, we think meaningful psychotherapy, what enhances neuroplasticity, is actually doing something from an allostatic load perspective, meaning increasing connectivity. Is that something you could say a word or two about? What is psychotherapy doing in the brain?
So I'm not a neuroimaging researcher, but my neuroimaging colleagues have been able to isolate neural changes associated with psychotherapies, and to some extent, the changes that take place are dependent on the type of psychotherapy that is administered, which would make sense, right? So, in some cases, it's enhancing connectivity in regions of the brain that are responsible for mood control. In other areas, it may be damping down, for instance, overactive reward circuitry. These are, sort of areas of inquiry right now, because again, we know that psychological interventions have biologic effects, and they may not be the same effects as pharmacotherapy, which might explain why these can work in a complementary fashion to optimize outcomes for patients. So I think that this is something that's super interesting, kind of a growing area of research, and a really important question.
And as a kind of a fitting ending for our conversation, I want to throw out the word deprescribing, something that you and I have been collaborating on for now quite a while through an initiative with the American Society of Clinical Psychopharmacology, the ASCP. That is to say that the purposeful identification of an endpoint for an intervention. So we often think about deprescribing of pharmacologies. You've had your course of treatment, and we'll now stop it. Or we won't stop it because we're concerned about the risk for relapse. My question for you is in more the psychotherapeutic realm and what's known these days about endpoints in psychotherapy and the twofold, the deprescribing of a psychotherapy. How do we reach an endpoint? And how do we think about the psychological ramifications of deprescribing a medicine?
Oh, You really are on giving me the hard questions. Okay. I mean, these are important considerations. I think I, let's talk about how psychotherapy can facilitate pharmacotherapy deprescribing, because I think that as we've talked about, psychotherapy has distinct effects and are very efficacious and indeed effective treatments for depression. And so, if one wishes to deprescribe a medication that is no longer effective or that has an undue side effect burden, either substituting or combining the pharmacotherapy with psychotherapy and transitioning the work from the medication to the psychotherapy makes a ton of sense. We can also use the kinds of strategies we use in psychotherapy, like cognitive strategies, supportive strategies, to help provide support for a patient who is going through a deprescription process in order to ensure their safety and to provide them with skills that may enable them to cope as the medication is withdrawn for whatever reason it's withdrawn. Whether there could be a lot of different reasons why you might choose to do that. In terms of
Right, but the messaging all important would be not that I'm abandoning you by taking this thing away, but rather I think you have built a kind of a resilience where it's reasonable to test your ability to move forth without this medicine.
Right. There are some studies in CBT actually that show that there's more enduring effects of psychotherapies than medication, because the medication, once it is withdrawn, no longer works. Whereas psychotherapies can give people skills that they can continue to use indefinitely. Now, it's true that some people might need a booster session, that, the concept of maintenance therapy and maintenance treatments in psychotherapy is also relevant, because we forget things or we come up against new situations where we need kind of a reuptake of our skills to help us cope optimally. But there is some advantages to psychotherapies over pharmacotherapy because we're giving people enduring skills, and indeed those can be used from the outset. You just start with the psychotherapy, or as you mentioned, like in a sequenced fashion, as you deprescribe, sort of transitioning over to some of these more skills-based practices, which may be an adequate substitute for what the medication had been doing.
So a taper approach, I mean, a predefined endpoint, there's often this sort of perception that psychotherapeutic endeavors either are arbitrarily time limited. I guess there's a literature with the short-term deliberately focusing on brief psychotherapies, but in terms of a logical endpoint, treating to remission, how much does one forecast in the course of a psychotherapy? Here are the goals of treatment. Here are the targets. Here's what we're looking at. Here are the benchmarks. And, let's think about an endpoint, at which point we can then reassess. If a relapse occurs, we can, as you say, have boosters, but sort of thinking almost the way you would about a medicine, the way you think about interjecting a psychotherapy.
I mean, there's some data that combination medication and psychotherapy increase the likelihood of a sustained remission, and that using them in combination might increase the odds of you're doing well over time. In terms of thinking about when we stop them, I mean, there's an artifact here of clinical trials design. So we don't have studies that follow patients for an infinitely long period of time. But if we look at sort of common benchmarks for clinical trials, say at 12 months, at 24 months, which really is sort of, the outer reaches of maintenance treatment studies. I think for the more highly recurrent disorders like bipolar disorder or highly recurrent unipolar depression, it does seem like continued treatment, even perhaps at a reduced frequency, is necessary to preserve the response. But for somebody with, say, a single episode of depression, it appears that a targeted acute treatment, either with psychotherapy alone or in combination with pharmacotherapy, can be given acutely and then discontinued after the treatment is completed. And so these are complete packages, these evidence-based therapies, and that people are likely continue to remain well at 12 and 24 months. So I think in part it depends on who you're treating, and like any chronic illness is a needs chronic disease management. So it doesn't make as much sense to think about cessation as it does to maybe reduction with booster sessions. But these are important and thorny questions.
The maintenance phase of a psychotherapy, I would imagine, looks different than the acute phase. I'm thinking of a bipolar patient that I treat who's now very well steeped in IPSRT, thanks to a referral from you, by the way, from a couple of years ago. And this person is now taking an international trip and is concerned about crossing time zones and stresses, and was saying to me, I'm concerned about the social rhythm disruptions that might be occurring in the course of my trip, not to mention the circadian dysrhythmias that will come from time zone changes. She's got the lingo down pat. She needs no psychoeducation. She's asking the right questions. And she's saying, I wonder if I should make a recontact with the IPSRT therapist I had been seeing to kind of not get a brush up or fresh up, but so much as just to say, look, I know the choreography, but I just kind of want to refine my plan for an anticipated set of events that is likely going to be a perturbation to my evenness. That sounds like a good maintenance.
Yeah, I mean, this sounds like a pretty sophisticated person who's able to sort of recognize their stressors. Well, yeah, but it sounds like they know themselves, they know what they need, and and they have a lot of self-agency, and that makes perfect sense to me. From the clinical trials data, there have been studies that have compared weekly to twice monthly to monthly maintenance sessions of psychotherapy. And there, over time, and this is in unipolar depression, there actually is no difference in outcomes based on frequency. So, sort of the conventional wisdom is monthly check-ins is probably sufficient for individuals with, and the same thing is true that we've done in bipolar disorder. So I think, sort of a baseline place to think is like monthly maintenance sessions to continue to support the gains that were made in an acute treatment for somebody with a more chronic illness like recurrent unipolar depression or bipolar disorder. But then again, we always want to tailor our treatments for the individual, and some people might feel that they need a little bit less because they really get it and they're able to use other coping strategies, whereas there are maybe other people who struggle a bit more and need more frequent help. So I'd say, kind of our modal frequency would be monthly, with the capacity to flex that based on patient needs.
Tailored treatments, one size fits one. Fair to say?
Fair to say.
As a rule of thumb in psychiatric treatment. Holly, I want to thank you so much for joining us today. We could go on and on and on, as we both know, but for now, this is a good place for us to stop. It's been a really nice overview of some of the core concepts and the active ingredients of depression-specific evidence-based psychotherapies and how those interface with pharmacology treatment and times in which the combination may be optimal, so that our listeners will hopefully have a better sense of when and how to prescribe the best treatment for a specific patient. So thank you, Holly, for joining us. Thank you all for joining us today, and we'll see you again soon on Brain Trust, Conversations in Psychopharmacology. I'm Joe Goldberg. See you next time.